Hi, I'm Gavin Nimon. I'm the Orthopaedic Coordinator for the Musculoskeletal Program for 4th year medicine. I'm going to give a video on the shoulder examination. Now, I'll start off by saying really before you actually assess a shoulder or any condition in orthopaedics, you need to know what conditions can occur. And as such, in the main section on the Canvas website, we have a video outlining the different conditions that can occur in the shoulder, the traumatic conditions and the elective conditions, and I'll refer you to that video. That video outlines all the different conditions, both electively, which would predominantly involve the rotator cuff spectrum, frozen shoulder, arthritis, and referred pain from the neck. Also, the traumatic conditions such as fractures, dislocations, and infections. When you actually are assessing a patient, it's important to actually take an appropriate assessment. And really, most times, patients might present with pain. And really, you need to know where the pain occurs, the site of a pain occurrence, the radiation, what makes it worse and better, and any other associated factors. We also need to know what limitations they might have as well. They may have limitations in function, such as in dressing, self-care, toileting, or even just normal day-to-day life and work aspects. And you also need to know what other factors might be occurring too. Is there problems with stiffness or deformity, or is there actually instability that's causing them to present? Part of the whole picture also is tainted by the past medical history. Has the patient had previous surgery? Has there been previous trauma to the area, which makes it more of a traumatic presentation, or an old traumatic presentation which is now presenting an elective issue, such as a significant history of dislocations leading to recurrent dislocations leading to secondary arthritis later in life? And also what treatment they've received. Have they received any physiotherapy? Have they had any injections? Have they had any surgery? So all these things that need to be taken into account. But in general, when we are looking at a patient, we need to assess exactly the history will help us to find what the most likely diagnosis is, and then the examination helps us confirm that diagnosis. If it's pain, is the pain felt predominantly anteriorly, which will make you think of a glenohumeral joint, such as in a frozen shoulder or arthritis? Is the pain felt laterally in the subacromial space radiating down the arm, which makes you think of a bursitis or tendinopathy or rotator cuff tears? Or is it pain posteriorly between the shoulder blades, in which case that would make you think more of referred pain from the cervical spine. And usually that patient would refer to neck pain or shoulder pain as being up here, which is really the base of their neck, going down the medial border of the scapula. If it's stiffness, that makes you think more of arthritis, but it was instability, which makes you think of either recurrent instability problems such as dislocations, or is it feel like their shoulders wants to give way when they throw something, which makes you feel of a thing like a labral tear. So basically the history of pain, the site of pain, and also the associated features that go with the pain helps taint what you decide is a diagnosis. We come to take an examination, we then proceed to actually assessing the patient. It's very important always to use the hand gel, okay? So particularly in these COVID eras and post-COVID times, the hand gel is very important. So always remember to place the hand gel on your hands before you examine a patient. Now we take along our patient. First thing to do is observe him, okay? See how he's standing, if he's standing normally, if he's standing with an abnormal gait or abnormal stance. Is he leaning one way, or is he protecting it? Is he holding his arm in a sling? Has he brought along any slings to protect him? So has there been any aids to help him with day-to-day life? We then ask him to undress. And you can just take your jumper off, please, Adrian. And as he undresses, we can see he takes his jumper off smoothly, and there's good range of the shoulder motion. If he was struggling and having trouble lifting one of the arms up, he might use trick maneuvers to get his. Now, we obviously want to look from all directions. We usually ask the patient to stand looking at us. We look from the front, and we're looking for the shape of the shoulder. We're looking for any wasting of the deltoid, the shape of the AC joint, which is in this area here, the proximal shoulder, and also if there's any scars. We're looking from the front. If you turn side on for me to face that there. Looking from the side, looking for any scars, and then posteriorly turn around and face away from us. And we're looking from the back. We're looking for wasting in the supraspinatus fossa or in the infraspinatus fossa. Turn around and face us again. Okay. And so if there'd been a dislocation of the AC joint or a subluxation of it, the lateral end of the clavicle might be sitting up. The same can occur at the sternoclavicular area as well. If there's any signs of a glenohumeral joint previous surgery, there might be a scar on the front of the shoulder. When you're looking, you also need to look in the axilla. If you just bring your arm out the side and make sure there's no scars in the axilla as well. And of course there's none here. Now put your arm down for me, please. Now then we go to palpation. Now palpation is fairly straightforward because the shoulder is quite subcutaneous. We can start from the medial border of the sternoclavicular joint and just press along the clavicle, medially, along the clavicle, and just towards the lateral end you'll feel the AC joint in this area, just around about here, which will be just above the coracoid. So the coracoid will be here, the AC joint will be here, and you'll see if there's any tenderness along the way. Always ask the patient, are you sore in any way? And I usually like to say, look, I'm going to be looking at your shoulder. If there is some discomfort or pain, please let me know. All right. We then can feel in the front of the shoulder. We can feel down the lateral aspect of the acromion and the subacromial space. So we bring the arm up and put it in this position. You should be able to feel a bicipital groove, which is usually just here. You internally and externally rotate the arm, you'll feel the bicipital groove and the biceps tendon in this spot, just there. And if you ask, is that sore along that spot, and see if it's tendon along the long head of biceps. In this area, just lateral to it, or just posterior, is the supraspinatus insertion, and anterior is the subscapularis insertion. Is there any tenderness in this spot as well, or the subacromial space? If we turn side on, we can also feel along this, or turn around the back, you can also feel along the spine of the scapula, here. Supraspinatus fossa and infraspinatus fossa to see if there's normal muscle bulk. Thank you, Aidan. Turn back around again. So we've done a palpation, looking for the sternoclavicular joint, the AC joint, the coracoid, the bicipital groove, and the rotator cuff muscles. Then we'll go for motion. Now I think, well, I usually like to use the rule of threes for a lot of the way I like to think about examinations, and in the shoulder there's no difference. There's 3 planes of motion. There's forward flexion and extension, abduction and adduction, and internal and external rotation. Really the 4 movements that are most important are forward flexion. So I find it very hard not to do the next step. And that is when I ask them to move, I would like to put my hand on the shoulder to feel for crepitus. If there's a type of crepitus, it can either be a soft tissue crepitus, that often goes with bursitis, or it can be a bony crepitus, which you feel with arthritis. Okay, so we're feeling for crepitus and ask them to move. Just turn facing that wall over there, and just lift your arm straight up towards the ceiling. As he brings his arm up, we're looking how far you can get him up from into a neutral position, straight up. That's actually, if you think of it as a goniometer, he's gone up to about 160 degrees there. And I'm feeling for bony crepitus, which I can't feel any. Okay, can you go any further than that? And he's going up to 480 or a bit past it. And down again. Now turn and face the camera. And I'll put my hand, I'll just turn around for a second, Aidan. I'm putting my hand on the angle of the scapula now. You feel the angle of the scapula, it's just in this area, just here. You can actually feel the scapula subcutaneously. Turn around and face the camera. And I'll ask you to bring the arm out to the side. And turn your palm to the ceiling as you do. And now we're abducting the arm and seeing how much range of motion again there is. Going from 0 up to 180 degrees. Okay? Back down again. And if there was limited motion, I'd be seeing if the scapula moved early. If the arm could only come up to about 80 degrees and on forward flexion was similar, and if there was reduced motion, I'd test it passively. And when I'm doing testing it passively, I've got my hand on the angle of the scapula to see if the scapula moves early with it. Because if the glenohumeral joint is totally solid or fused, either from osteoarthritis or from previous surgery or from frozen shoulder, then the scapula will move early. And despite there being no motion in the glenohumeral joint, the scapula can move with it. And you can get forward flexion and abduction to about 80 degrees. What you can't do if there's no motion in the glenohumeral joint is externally rotate. So what we next do is, before we, once we've assessed passive motion, I would test external rotation. So, and can you keep the arm by the side, just bring the arm out to the side. And we can assess how much external rotation there is. And if there's a stiff glenohumeral joint, there will not be any external rotation. So, if we have forward flexion, if the forward flexion is full and abduction is full, we test external rotation to see how much range of motion there is as well there. The final range of motion is internal rotation. Just face it away from me now and face the wall, and just bring your arm up your back and bring that up as high as you can and see how high the thumb can get up. It should get up between the scapula, and you can always compare that to the other side. That's internal rotation. So turn and face the camera again, Aidan. So the 4 movements that I like are forward flexion, abduction, external and internal rotation. Now if any of those movements are reduced, we then assess passive motion. Okay, always checking the patient, because if it is reduced, it might be from pain, and therefore we need to make sure he's not particularly sore when we do it. So if he bring his arm up to about that far, we would then see if we can hold in the scapula and hold in the angle of the scapula, see how much further we get it. So we do active motion, then passive motion. down again, thanks Ed. And we'll do the same on abduction, and we'll do the same on external and internal rotation, but predominantly external rotation. If the range of motion is limited both on actively and passively, and there's early movement of the scapula, that implies that the glenohumeral joint is stiff, and the most common cause in a young person would be frozen shoulder, and an older person would be arthritis. If, however, passively there's good motion, but actively there's not, it implies that the actual shoulder can't move, either due to a large rotator cuff tear, or perhaps due to nerve entrapment in the neck, such as a C5 nerve root. Once we've tested the range of motion, both actively and passively, we then need to test muscle power. The way we test muscle power is by asking him to bring his arm upright into the sides, again into the neutral positioning, put both arms together, just turn and face me a bit, Aidan, if you can, and keep your arms just together like this, and ask him to push out against me. So we're testing, I'll just show on one hand, push out against there, we're testing power of external rotation, which would be power of the infraspinatus muscle. We can also test power of internal rotation by, again, to putting the hands together, which would be subscapularis, but a better way is to do the belly press test, and that's where you bring the elbow forward and hold it forward with your hand, where you put the hand on the tummy. Just face the camera a bit there, Aidan. So we're holding the elbow forward and pull into your tummy for me, please. And that's testing power of subscapularis. Another way of doing that is just to face the wall there, is to put your hand behind the bottom in this position, just face this wall here now, Aidan, thanks. Just turn around a bit more. In that position and push away. And this is called Gerber's lift-off test. The only problem with this test is that it has to be, thank you Aidan, has to be good range of motion beforehand, and if they're a bit sore they have trouble getting their hand into that position. So we've tested the power of infraspinatus and subscapularis. Last one to test is power of supraspinatus, and we put your arms into this position, so forward and slightly abducted and internally rotated and push up to the ceiling. And that's telling power of supraspinatus. Muscles. Okay. To test teres minor, you can test that. Probably the best way is to bring the arm up into this position and roll it in, and it's called Hornblower's sign. So the arm abducted, internally rotated, and push up against me here, and it's actually power of external rotation in that abducted position, and that's called Hornblower's sign for testing for power of teres minor. Next, moving on to other special tests, we could look for winging of the scapula. So if you turn and face the wall, and just push off the wall as a push off, and we're looking to see if the scapula wing in any way, if they stick out further. Just push against the wall there, Aidan, and there's no winging there, okay? Moving back on, turn around and face me now. Now we're going to look for signs of impingement. Now there's a couple of impingement signs. The nearest impingement sign is if you just face towards that way, Aidan, and just lift your arm straight up towards the ceiling, and nearest impingement sign is pain between the 70 to 120 degree range. It's known as a painful arc. And if you get pain there and it gets less pain at the top, that would imply bursitis. Another way of testing it is called Hawkins impingement sign. Just face the camera again, thanks Aidan. Bring your arm up forward, flex the arm and roll it in. And that will cause impingement in the shoulder in this area, with pain felt in this spot. And that's called Hawkins impingement sign. That's implying some bursitis or tendinopathy if the person's older, or even a small rotator cuff tear. Of course, if they had weakness of power, that imply a larger rotator cuff tear. Now, if a person has AC joint arthritis, which is very common, particularly after Aussie rules football or lots of injuries, then they may get some pain at the AC joint. That would have been tender when you're palpating this area, but they could also have a painful arc, but it's not actually the arc at 70 to 120, it's actually over 120 degrees in the end range of motion. So if he brings his arm up, and just out the side, sorry, just bring it right up, and if he had pain at the end range of motion, that would imply, and back down again, Aidan, thanks, that would imply AC joint arthritis. Now there's a couple of other tests you can do for that. One is a scarf test, where you bring your arm across your chest and see if that causes pain. Okay, I've never found that to be that useful, but a very good test described in Victoria is actually the cross-arm adduction test. And if you bring the arm across the chest with the elbow straight and the hand internally rotated and push up against resistance, if they get pain at this spot, that's actually pretty good for assessing AC joint pain and AC joint arthritis. Okay, that also can be painful just after a sprain as well, although usually they would have reduced movement. Moving on to other special tests that we need to be aware of is the long-headed biceps tendon. There's a couple. If we had tenderness and long-headed biceps, then you may think there's a biceps tendinopathy, which goes in hand often with rotator cuff disease. A couple of tests of testing for that is testing for pain in the bicipital groove on forward flexion with the arm in extension, or keeping the elbow straight and holding in that position with the hand supinated and getting some resisted motion, trying to pronate the hand and extend the wrist, and if they get pain in that biceps region as well. Usually the most specific test is for long-headed biceps, is for palpation of that bicipital groove right at the start. There are other tests looking for labral tears. The classic one is O'Brien's test, although I find that's not that useful because it actually puts the arm in a position which is often painful for impingement, and also is not dissimilar to the test for AC joint pathology as well, which is more common. But the test is supposed to be with the arm, the shoulder flexed across the chest, and then in this position with the forearm in a pronated position, you push up against resistance, which is very similar to where the AC joint becomes painful as well. And if it's then relieved by the arm in the supinated position and the shoulder more neutral, it's supposed to be positive for labral tears or superior labral tears of the biceps avulsion of the labrum off the edge of the glenoid. Finally, the other test to be aware of is test for instability. A diagnosis of instability is made from the history. The person may have had a proper dislocation of their shoulder while playing football after falling and landing awkwardly, or landing with their arm being held in the abducted extreme rotated position, and then they have a history of recurrent dislocations. Instability where the shoulder feels like it's popping out of joint or where it's truly popped out of joint helps diagnose the story of instability. Now, when assessing for instability, there's three types of instability. There's been inferior instability, anterior instability, or posterior instability. The most important part is to assess the general ligament laxity anyway, and we can assess that by looking for 9 signs, 4 on each side plus a generalized sign. And those are ability to hyperextend the fingers. Can the patient bring the fingers back parallel with the forearm? So if we just turn side on there, and can you bring your fingers back parallel with the forearm? And it's got a bit of hyperextension there, so a little bit of degree. Now also hyperextension of the thumb. Can he bring the thumb back onto the forearm? So if we bend the wrist and the thumb, so just like this, Aidan, so other way, bend this wrist and down there, and can it come right back onto the forearm there? He's actually being able to bring it back a little bit more there too. Can he hyperextend the elbows? And he's got a few degrees of hyperextension there as well. So if we compare both sides, that's 3, and if he does it on the other side, it's another 3. Can he hyperextend his knees? And then finally, can he touch his palms to the ground without bending his knees? So if you add up 3 for the upper limb, 2 for each knee, and the ability to touch the palms to the ground without bending your knees, that adds up to a score of 9. And a score of 5 or 9 equates to a generalized ligament laxity. Generally, most people who have a history of instability have some ligament laxity in themselves anyway. Finally, we then move on to the specific tests for instability, and these will be shown with the use of the examination couch. So with the patient sitting on the side of the couch, I like to look for inferior instability by checking the sulcus sign. That's where we put your arms on the lap, both arms, and I come from the front and just pull on the arms, just relax your arms, let them go really floppy, and we're looking to see, I'll just do it on one arm, we're looking to see if a little sulcus appears just lateral to the acromion, just by putting some pressure on that. And he doesn't seem to have any of that. Sometimes in some patients with really lax ligaments, the whole ball almost subluxes down inferiorly. We now focus on the left shoulder, just for the rest of the examination. I'll get you to lie flat on your back there for me, Hayden. Yeah. We can test for anterior-posterior instability by allowing the arm to go very floppy, and just hold it in the arm, and just with the other hand, just try and mobilise it posteriorly and anteriorly. It's almost subluxing the shoulder forward and backwards. Okay. If there's a degree of instability, the shoulder should come forward about 50 degrees normally, but if it comes further forward or further back, when you do that ballotment of the shoulder, that suggests some laxity. We can then test for anterior apprehension. Now this can be done stand up in some clinics, that people like to do it standing up, but with the arm externally rotated and abducted and extended, the shoulder should feel like it wants to pop out of joint if they've got some instability. And that's called apprehension sign. If the patient is made more comfortable by applying some forward pressure on it as they do that same manoeuvre, that's called relocation. And if it becomes more unstable by putting some posterior pressure on it, that suggests a positive apprehension. Okay. The final test is jerk test, or posterior jerk, and that's where we try and sublux the shoulder posteriorly by bringing the arm up across the chest and trying to put some posterior pressure on the shoulder. And that one usually is very hard to assess that with the patient awake, but that can suggest that there's some posterior instability. The final part of the examination really is neurovasculature. One of the causes of shoulder pain can be referred pain from the neck. And so often it's very important to check that the pain isn't coming from the neck. I often try to do this at the start But for an OSCE examination, you might want to do it at the end, just for time constraints. But be aware, the neck can cause referred pain into the shoulder, particularly if the neuroforamen of the cervical spine get entrapped in certain positions. And the classic one is extension, lateral flexion, and rotation can trap the nerve roots in the neck to cause referred pain into the shoulder. So if I ask Aidan to extend your neck, and then tilt your head to the side, this side, and then rotate it around to my hand. And if he's getting pain there referred down his arm, that would suggest referred pain from the neck. And you can try and improve that or increase it by putting a little bit of forward pressure on it or posterior pressure in that position just to see if that makes it worse. If they had any signs of referred pain into the shoulder and complained of some numbness or pain shooting at their arm, you then do a peripheral nerve examination looking at the individual nerve roots, along with also finishing off by testing pulses in the hand as well. So I think that's a brief rundown of a shoulder examination. I hope it's been useful. Thank you.